Okay, this is a lecture on inborn errors in metabolism, amino acidemias, your organic acidurias, urea cycle disorders, glycogen, sugar metabolism. The purpose of the genetics portion of this inborn errors in metabolism is to more talk about the clinical perspective. So I'm not going to spend as much time talking about all the enzymes. I'm going to review them a little bit. But this is more of how patients present. And they really present variably. Nonspecific lethargy, decreased feeding, vomiting. These symptoms are common in a lot of things, but they can progress to seizure and comas. And again, we can see this in a lot of different disorders, especially in the newborn, including severe congenital heart defects or sepsis. So a newborn crash is defined as the baby is born, they look good at birth, those APGAR scores. APGAR scores are probably the most inaccurate measurement of a baby's well-being, but that's just my opinion. And the reason with a metabolic disorder that they look so great is that the placenta, if there's a missing enzyme in the baby, the mom is filtering it through the placenta, so they're not accumulating byproducts. But once you cut the cord, then these byproducts start accumulating. And it starts slowly, non-specific. They're not feeding as well this feeding. They're spitting up. They're not as, they're more lethargic. Progressive, and then it progresses to seizures and coma. Sometimes there's an abnormal odor to the urine. I'm going to talk about these abnormal odors because when we're trying to figure out what this is one of the clues. And when you're taking STEP, and this is an outrageously large amount of information, we realize this is inborn errors because of this new curriculum is all shoved into this case, is a bit overwhelming. So let's talk about the differential diagnosis for the newborn crash. And I should have sepsis like the largest. Sepsis, sepsis, sepsis. So here I am, the geneticist, but I am telling you, if somebody's told me there was this baby that looked great, now they look horrible, the first thing, the second thing, and the 10th thing that I'm going to think about is sepsis, because babies can get really sick really fast from sepsis. Adrenal insufficiency, congenital heart disease, because the heart has certain openings so that in utero the blood is shunted from the lungs, and then after the baby's born, it changes its whole anatomy. So sometimes babies are fine until all of a sudden the PDA closes and then, the baby's in a lot of heart issues. Or asphyxia. And asphyxia could occur right before birth and the baby looks okay at birth, but then all these tissues start dying and then it looks horrible. But you also have to keep on your list of the newborn crash amino acid abnormalities, urea cycle abnormality, organic aciduria, or mitochondrial disorders. And we're not going to be talking about mitochondria today, but I'm just, putting it in here. This is not a perfect way to look at this, but I'm just going to talk about it, and we're going to kind of look at this. There's an activity, it's a take-home activity, but if a baby is having the newborn crash, lethargic, coma, seizures, maybe vomiting, maybe an abnormal odor, is the baby acidotic? And if they're acidotic, where is that acid coming from? Is it coming from lactic acid? As in the case of some mitochondrial disorders, again, you are not responsible to know this. We will learn this next year. Pyruvic carboxylase and pyruvic dehydrogenase. That's primary lactic acidosis. Or secondary lactic acidosis, such as glycogen storage disease, tyrosinemia, galactosemia, coarctation of the aorta. Some of the highest lactic acids I've ever seen are because of coarctation of the aorta. Or is it coming from lactic acid, or is it coming from organic acids such as propionic, methylmalonic, maple syrup urine, glutaric? If the baby looks horrible but is not acidotic, what is the ammonia? And when it's very elevated, we're going to talk about urea cycles. And if everything's normal, it could still be something like PKU, because they actually, the baby, well, PK usually present a little bit later, but they don't have any particular metabolic abnormalities. So, but let's just talk about metabolic acidosis. decreased blood pH caused by an accumulation of hydrogen, decreased bicarbonate, and decreased PCO2 because of compensatory hyperventilation. The question to ask is the metabolic acidosis the result of an abnormal loss of bicarbonate, such as diarrhea, or an accumulation of a fixed acid? And the way we do that is the Henderson-Hasselbalch equation to measure the anion gap, which is sodium minus plasma chloride plus HCO3, and normally it's between 10 and 15. Metabolic disorders result in the accumulation of organic anions. So clinically, there's always a persistent metabolic decompensation with acute decompensation. So here's just another way to look at this. You got metabolic acidosis. Do you have a normal anion gap? Normal anion gap is because of loss of bicarb, such as diarrhea and renal tubular acidosis. If you're acidotic and you have a normal anion gap, then you're thinking about the baby's losing too much hyperchloremia, you're losing too much bicarb, diarrhea, renal tubular acidosis. But if it's expanded, it's an accumulation of fixed acid. Now, we also have the diabetes 1 and 2 cases. But if this was a 5-year-old or a 10-year-old or a 15-year-old, the first thing with somebody with metabolic acidosis and an expanded anion gap is ketoacidosis, is diabetes. It's the first thing, if it's normal anion gap, you're thinking diarrhea. If it's expanded, you're thinking maybe ketoacidosis. But this is where the age of the patient is really, really important. If this is a newborn, neonatal diabetes makes inborn errors of metabolism actually look common. So it depends on the age of the baby. If this is a 5-year-old that comes in acidotic with an expanded anion gap, again, you're going to be worried type 1 diabetes. If it's a older, like 15 or 20-year-old obese or an adult, then you're going to think maybe type 2 diabetes because of the ketoacidosis. However, if this is a 1-day-old or a 2-week-old, you're going to be thinking of a metabolic disorder or maybe even a lactic acidosis because of either a glycogen problem, again, maybe a heart defect, things like that. So let's talk a little bit about the inborn errors of metabolism. And one thing I know biochemistry went through a lot of stuff, but to be honest, you do not need to be able to differentiate one organic aciduria from another. I don't even get asked that on my boards because I'm not a metabolic specialist. So there is many defects that result in a group of organic acidurias. Clinical features usually include decompensation the first 2 weeks of life. Again, the timing matters. It can present later if there's like a partial block. And the clinical features include acidosis, elevated anion gap, elevated lactic acid, and hypoglycemia. So here are the organic acidurias. And again, you're not expected to differentiate one from the other. But we have methylmalonic, isovaleric, propionic, maple syrup urine disease, and glutaric. And there's some key features of these which we're going to go over. But the main things is, again, they have acidosis. Sometimes on amino acids, there's an elevation of glycine. One thing, just when you get onto the floors, if somebody does an amino acid and there's this taurine is elevated or some other little thing, just look at the bottom, the interpretation, because most of those things don't matter, but glycine can matter. Hypoglycemia, a little bit of neutropenia, bone marrow suppression, and mild hyperammonemia, and this is because the liver is unhappy because of all this acidosis. So let's talk about glutaric acidemia. This usually presents after age 1, so often it presents a little bit later compared to the rest of the organic acidemias. And prior to the first significant episode, there might be an enlarged head, and it's really not the brain's enlarged, it's actually extra fluid, so it's known as microcephalic macrocephaly. Often children have normal to, just mild delays until the first episode. Other features include profuse sweating and unexplained fevers, irritability. It's inherited and autosomal recessive. And one thing, this is just kind of anything that has to do with an enzyme is usually recessive. You have 2 copies of your enzyme, so you have 100% of the enzyme. Most people don't have any symptoms unless they have 20% of their enzyme. So if one is working and one isn't, you got 50% of your enzyme. So just as a general rule, if you had no idea what caused this, we're going to talk a little bit about X-linked things, which is a little bit more complicated, but most metabolic disorders are autosomal recessive. So if you never heard of the thing in your whole life and you had to just take a wild guess, this is a really good wild guess. One of the other things is in glutaric acidemia. It's more common in the Pennsylvania Amish. So if you move to Pennsylvania, you might hear a lot more of this. So diagnosis, elevation of glutaric acid in urine organic acids. So if you were reading this thing and it said the urine organic acids showed elevation of glutarol, CoA, blah, 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 glutaric, whatever, then you'd be like, oh, that could be glutaric acid, okay? Don't overthink it. MRI, but the other thing is the MRI can show lesions to the basal ganglia, but also subdural hematoma. So this is little extra blood, a subdural hematoma. And this occurs because of bleeding from tearing from the vessels. Remember I said it was microcephalic macrocephaly, there's extra fluid, so sometimes there's tearing. But subdural hematomas can also be mistaken as abuse. So if a child came in obtunded and the doctor was worried that they were septic, and they were surprised to see that there was a subdural hematoma, then you should maybe think glutaric. If a child came in obtunded with bruises, retinal hemorrhages, and a depressed skull fracture and a subdural, it's probably not a metabolic disease. However, there's nothing wrong with studying urine organic acids, so that if somebody asked you once, did you consider that this was a metabolic disease, you say, of course I did, and I did organic acids and they were normal. Anyway, moving on, maple syrup urine disease. Babies deteriorate in the first 1 to 2 weeks of life. Again, earlier than glutaric. Ammonia can be normal to mildly elevated, lactic acid's normal, glucose is normal. Amino acids show elevation of branched chain amino acids, including leucine, isoleucine, and valine. And there's a maple syrup or sweet smell to the urine or earwax. Again, it's an enzyme, autosomal recessive. It's a very rare, 1 in 100,000 to 1 in 300,000. However, it's more common in the Mennonite population, and it's also more common in Ashkenazi Jewish and French Canadian. Why do I give you this? Because sometimes if you have a patient of those particular ethnic backgrounds, it's something that maybe should move up a little bit more in your thought process. Or if you're taking an exam and somebody tells you what the ethnic background is, you should think about it. Anyway, maple syrup urine disease is caused by a non-functional enzyme of the BCK, the branched chain keto acid complex, which catalyzes decarboxylation of alpha keto acids of leucine, isoleucine, valine to the respective branched chain acyl-CoAs, which I know in biochemistry, you got all that. The serum amino acids, when we look at them, show an elevation of leucine, isoleucine, and valine. Again, the branched chain amino acids, that kind of pattern. Elevation of isoleucine is actually what results in the sweet smell to the urine. However, the elevation of leucine is the problem. Leucine is transported to the brain, and then it's converted to glutamate and glutamine, which result in elevated levels of glutamate and glutamine in the brain, result in lethargy and damage to neurons. So the management for maple syrup urine disease is a diet low in branched chain amino acids and a low protein diet. So let's talk about amino acids. Amino acids are the building block of proteins. There are essential amino acids, and the remainder are made from each other. They're converted from one to the other. There are a number of enzymatic processes that convert one amino acid to the other. And one we're going to talk about is phenylketonuria, or PKU. Phenylalanine is converted to tyrosine through this enzyme, phenylalanine hydroxylase. And when it's not functioning correctly, then phenylalanine is shunted to phenylpyruvate, which is then converted to a number of acids. Now, we get our phenylalanine from our amino acid pool that we get from eating protein. When I look at amino acids, while the tyrosine might be a little bit low, that's not really our problem. Our problem is the elevation of the phenylalanine. This acids in the brain cause a lot of damage to the neurons as they're developing. If untreated, an infant can lose 50 IQ points in the first year of life. However, if we treat them, they can have a normal cognitive outcome. Symptoms of untreated PKU include a mousy odor and progressive microcephaly. So the management is a low-protein diet with limited phenylalanine. Kuvan is a medication that can improve enzyme function in some patients with deficient but some enzyme activity. And pharmacology will go into more detail about that. But another thing I want to talk about is Diet Coke. So diet anything, Diet Pepsi, Diet Soda, and you'll notice if you have a can with you, it says phenylketonuria. This contains phenylalanine. So aspartame is really, has high levels of phenylalanine. So this is basically like poison to somebody with PKU. You cannot have, they cannot have diet sodas. They can maybe have a regular soda, but they cannot have diet sodas. The next thing I want to talk about is maternal PKU. If the mother has PKU, again, we've actually been testing this on the newborn screen for about 50 years, maybe more, maybe 60. Anyway, if we identify the baby in the newborn period and we put them on the correct diet, they can have normal cognition and grow up and have children. And when we first, when they first started treating children with PKU, and this is an incredibly restrictive diet, very low in protein, very low in a lot of things. They have to eat this special formula all of their life, and they have a very, very low protein diet. And we have to monitor the phenylalanine very, very closely. And it's a horrible diet. So what they used to think is, well, the brain forms in the first 5 years of life, so after 5, we could, release them from this very restrictive diet. The problem with that is the brain is not done forming at 5 years of life, and we did see patients with progressive problems like ADHD and loss of IQ points. And once you come off this diet, you're never going back on it because it's horrible. If you ever tasted real food, you wouldn't go back to it. But the other problem is women that have PKU, if their phenylalanine is not very, very severely restricted during pregnancy, that high phenylalanine is teratogenic to the fetus. So the high phenylalanine is a teratogen. It causes birth defects to the fetus. As I said, PKU is inherited in autosomal. It's an enzyme, autosomal recessive. The mother has 2 non-functional copies of the gene. But in order for the baby to have PKU, the father would also need to be a carrier. It's relatively rare. So the problem is when a baby is born to a mother with PKU, at birth they have microcephaly. Normal babies with PKU do not have microcephaly at birth because their mothers didn't have PKU. They didn't have elevated phenylalanine. It's a progressive microcephaly if they were untreated because their brain is being destroyed. But babies born to a mother with PKU, even though they have one functional gene in most cases from the dad, are born with microcephaly because of the elevated phenylalanine damaging their brain before they're even born. They also have risk of congenital heart defects and intrauterine growth defects. Again, a normal baby with PKU is going to be born healthy and normal, but then you cut the cord and the phenylalanine starts rising. This baby has problems before it was born. The next amino acid disorder I want to talk about is homocystinuria. And this is the inability to convert the amino acid homocysteine to cysteine because of the deficiency of this enzyme cystathionine synthetase. Again, I'm not going to go into a lot of this detail because I know biochemistry did. But when it can't go here, it goes here. It goes to homocysteine with the INE, which is excreted in the urine as homocysteinuria. The elevated homocysteine, because it can't get converted here, results in a prothrombic state that increases blood clots. So that's one of the complications in patients with homocystinuria. But unlike most metabolic disorders, patients with homocystinuria can actually have dysmorphic features, including they look what we say Marfanoid habitus. They have long fingers, they have hypermobile joints, tall, they might have a chest wall deformity. But unlike Marfans, they can have cognitive delays. And finally, patients with Marfans have an upgoing dislocation of the lens, but patients with homocystinuria, it goes down. And we're going to talk more about Marfans and the connective tissue block, but just homocystinuria and Marfans, they like to compare and contrast quite often. Tyrosinemia, another amino acid disorder. Elevation of tyrosine results in renal tubular acidosis and liver failure. The serum amino acids note elevation of both tyrosine and methionine. And clinical presentation varies, but usually includes failure to thrive a little bit later than some of the organic and amino acidemias that we talked about that can present early. And the urine can smell like rotten cabbage. Again, it's autosomal recessive, and management is a diet low in tyrosine and methionine. Nitrazone is used to prevent the formation of succinyl acetone. And if we catch this too late or it's not being managed correctly, liver transplant in severe cases. So this is just kind of a memory slide of urine odors and metabolic disease. I didn't talk about isovaleric. Here's another organic. Sweaty feet, maple syrup urine disease, sweet urine, PKU, not just but the whole baby kind of smells mousy, and tyrosinemia, rotten cabbage. So the next group of disorders I'm going to discuss is urea cycle disorders. And many of these urea cycle disorders don't present in the first 2 weeks of life. They actually present in the first couple days of life. The purpose of the urea cycle is to break down nitrogenous waste that we get from breaking down proteins and excrete it in a water-soluble method known as urea. So, ammonia combines with CO2 to make carbonyl phosphate, and carbonyl phosphate combines with ornithine through this enzyme ornithine transcarbamylase to make citrulline. Citrulline is then converted to original succinate lyase, and when that doesn't happen, the citrulline is really high, and it results in citrullinemia. Original succinate lyase actually makes arginine through this enzyme original succinate lyase deficiency, and lyase, and then when it's deficient, it's deficiency. And then arginine, the last stop, releases urea and goes back to ornithine. And when that cannot occur, this is known as arginase. So we're going to go over these a little bit, but I just want to go over this again. If we have OTC, the citrulline is actually going to be low because we can't go from here to here. If we can't go from here to here, the citrulline will be really high, and citrulline is seen on amino acids. The citrulline will be high, but the arginine is going to be low. The arginine is also going to be low in OTC, but not as low as it will be in citrulline, and definitely not as low as original succinate lyase. The citrulline, since it's not going this way, might be a little bit higher because it's backing up a little bit, but certainly, not as high as it would be if it can't go from here to here. And the arginine would be lower than this one. And then arginine goes to ornithine. So if the arginine is really high, then we're thinking of arginase deficiency. So symptoms of a urea cycle defect, because of the accumulation of ammonia, they're actually alkalotic. So they look horrible, but they're not acidotic. Their pH is like 7.5. It's like, oh my God. The ammonia can reach thousands and can do it very quickly. Elevated ammonia can result in excessive lethargy and sleepiness. So the ammonia in the brain causes lethargy. And elevated ammonia, the big issue is it affects the liver. So symptoms of hyperammonemia, as I said, is lethargy and liver disease. OTC is located on the X chromosome. So we're going to talk about that in a second. Serum amino acids show low citrulline and arginine. Urine organic acids show elevated something called orotic acid, and persistent hyperammonemia results in progressive cognitive delays. Males usually present in the first few days of life, but females can present later or sometimes be precipitated by an infection. And the reason for that is X inactivation. So females have 2 copies of this gene. One makes the enzyme and one doesn't. But it's not like a recessive gene that they're both on in every cell. In some cells, the female has the X on, and some it has the X off. Some females are lucky. Their entire liver has the X off is the one that doesn't make the enzyme, and their liver works just fine. And some females aren't lucky at all, that the X on in the liver primarily is not working at all. And then most 50-50, and they're fine unless maybe they ate too much protein. They ate too much protein, and they're dehydrated, and they're sick. So sometimes they present at different times. I've actually even seen men with a mild deficiency of this gene. The latest I've actually ever seen somebody is 65. They called me from the neuro ICU and they said, we have this guy with hyperammonemia and he's obtunded, and could it be a urea cycle? And I said, does he have delays? Because it usually affects the brain. And they said, oh no, he's the head of the Tollway Association or something. And I said, well, probably not, but send urine organic acids. And 5 days later they called me up and they said, Dr. Jones, the orotic acid's really elevated. I was like, okay. So we sent genetic testing and found out he had an adult onset mutation of the OTC gene. He was from a very large Irish family, and 2 of his brothers did as well, and he never had symptoms till he was 65. So I put him on a low protein diet, but his wife was very obsessive about it to the point that his BUN, one time he came in, it was 8, and I'm like, you've lived 65 years, you can have a steak, just make it the 4-ouncer. I didn't need to put him on arginine supplementation, but an infant, so you want a really, really restricted low protein diet, but again, you have to balance. Arginine supplementation, because again, in the urea cycle, you're not getting to the arginine. And this, even though these genes are in every cell in our body, the liver is the most important because the liver is what's responsible for the urea cycle. So in general, for urea cycle defects, a liver transplantation can actually cure it. And maintaining this normal ammonia is so critical, especially in early brain development. It's so difficult to manage that liver transplantation is what they're really trying to go to as much as possible. You learn more about this as you move forward, but one of the nice things is we can do a living-related transplant if one of the parents is a good donor. With OTC, mom may not be the best option if she's carrying this gene. Maybe it's dad. But anyway, if they can get a living-related transplant, that's the best early step. Again, the second step in this is citrullinemia. This is autosomal recessive. Males and females are equally affected. Babies present with hyperammonemia in the first week of life, and usually the first couple days. There's very elevated on the amino acids citrulline, and the organic acids again show the orotic acid. Management, arginine supplementation, low protein diet, monitoring for hyperammonemia, and again, liver transplant. Original succinate lyase, the third one on that group, again, recessive. The only one that's X-linked is OTC. That's something you need to remember. Patients present in the neonatal period, but sometimes they can present a little bit later. Hyperammonemia, arginine is deficient on amino acids, so arginine supplementation, low protein diet, and monitoring for signs of hyperammonemia. And finally, arginase, autosomal recessive. This presents a little bit later, and sometimes it can be what I call a masquerader of cerebral palsy. And cerebral palsy is a clinical term for increased muscle tone. And the reason for that is the chronic elevation of the ammonia, maybe not to the point that the patient is obtunded, but it's damaging the brain nonetheless. And unlike the rest of the urea cycles, the arginine is elevated. Symptoms can present sometimes with an current viral illness. Again, you're increasing your metabolic needs. And the treatment is a low-protein diet. And finally, the last thing we're going to talk about are the sugar metabolism. So galactosemia is caused by the inability to take galactose to glucose. And what is lactose made of? Lactose is glucose plus galactose. And glucose is easy to use, but galactose we can't use. We need to convert it to glucose. And there's actually 3 enzymes involved, but the most common is GALT, which is galactose-1 uridyltransferase. The GAL and GALC are also, but they're far less common. But if any of these enzymes don't work, we can't go from galactose to glucose. So galactose is then shunted to galacatrol. And galacatrol is toxic to the liver. And the other thing is this unmetabolized sugars are shown as reducing substances in the urine. So features of galactosemia include jaundice because of liver, enlarged liver, vomiting, and feeding intolerance, and E. coli sepsis. E. coli loves galactose. So when there's tons of galactose in the blood, it proliferates. We actually test most of these things, everything I've talked about today, we actually test on the newborn screen. Not that every newborn screen is a little bit different, so you don't necessarily are asked specifically about what's on Illinois' newborn screen because it's a little bit different than Indiana's, but most states do all of these things. But if you get an abnormal newborn screen for galactosemia on a Friday evening, you need to act right away, even if the baby is fine. You call mom, oh, the baby's great, blah, blah, blah. But if you didn't call, by Monday, this baby could die of E. coli sepsis. They can die within hours of E. coli sepsis. Untreated babies can rapidly progress to hepatic toxicity or death from bleeding or sepsis. So the treatment is a lactose-free diet, okay? The most important thing for any mom is to breastfeed. The problem is breast milk have lactose. I do not like to tell women not to breastfeed, but if you have a positive newborn screen for galactosemia, they can't have lactose. They have to be on a lactose-free diet, which is a soy diet. And as I said, this is tested for in most states. So it's not an easy conversation to have, but you have to tell this mom you can't breastfeed anymore until we confirm if you have galactosemia or not. There is a milder form of galactosemia known as Duarte variant where there's about 10 to 20% of enzyme. We used to treat them for a year. We now don't even treat them at all. But we need to take this seriously because the baby could die very quickly. And then let's talk about glycogen storage disease. So glycogen is how we store sugar, so when we need to use it. And so we take glucose and we make glycogen, and then we have to take the glycogen and use it for glucose. The problem is we're having a problem either making glycogen or breaking it down. The hallmark is the accumulation of abnormal glycogen in tissues, including the liver and skeletal muscle. Unfortunately, it's relatively uncommon. There are 2 groups, the hepatic group and the muscle group. In the hepatic group, the most common is von Gurke's or type 1. And this is going from glucose 6-phosphate to glucose. And again, I know biochemistry went into a lot of details. And then the debranching and branching. So we get to glycogen, then we have to break the glycogen down to glucose. And again, I'm going to save you going into all these details, so just refer to biochemistry. The purpose of this lecture is to talk about the clinical presentation. So the clinical presentation of von Gurke's or glucose 6-phosphatase deficiency, that last step to getting to glucose, is usually presents about 3 to 4 months of age. Again, not right in the newborn period. They have a huge liver, and they actually have they have these little teeny arms and legs, and these big cherubic cheeks, and this big belly. But they actually, and because of the hypoglycemia, they can have seizures. So you have hypoglycemia, lactic acidosis, hyperuricemia, hyperlipidemia. To prevent the hypoglycemia, you want them to always have an easy method of glucose, such as cornstarch. And you also want to remove all galactose and fructose from the diet. Muscle disorders include Pompe's, which I'm going to talk about next year. It's actually a lysosomal and glycogen storage disorder, so I'm not going to talk about it today, but we are going to talk about McArdle's and phosphofructokinase deficiency. So McArdle's is caused by the deficiency of the enzyme muscle phosphorylase, and the PYGM gene is inherited in autosomal recessive fashion. Again, it's an enzyme, probably recessive. Absence of this enzyme results in decreased ATP generation by glyconeolysis. Symptoms usually begin in the early 20s, and usually they start with somebody starts a new exercise routine. They started weightlifting, and then my muscles hurt so bad, and there's a lot of cramping. And then the next day they start seeing this cola-colored urine, burgundy-colored urine, but it's not blood. CPK is elevated. Creatine kinase, or CPK, is released from muscles when it's damaged. Next, when we talk about muscles, we're going to talk about Duchenne's, and whenever a muscle is damaged, it releases a lot of CPK. An elevated CPK is just an indication of muscle damage. If somebody had a crush injury, and they injured muscles, they would have a really high CPK. But the problem is this really high CPK can actually result in kidney issues. The diagnosis of McArdle's can be made by a muscle biopsy and certain stains, which Path will tell you, but I would actually just do a cheek swat and send a genetic test because it's less invasive. And 100% of patients with McArdle's will have 2 mutations of the PYGM mutation gene. Treatment: avoid strenuous exercise, IV fluids with glucose if the person starts, because rhabdomyolysis, unfortunately, it's kind of a progressive thing. Type 7 phosphofructokinase deficiency, this is also a problem in the fructose 6-phosphate to 1,6-diphosphate. It looks similar to McArdle's, except for the age of onset's a little bit earlier. It can present during childhood. It can have more hemolysis, really elevated uric acid, and exercise intolerance is worse after a carbohydrate meal, which a lot of people do before they do a, big exercise. So, take-home points. The age of onset of metabolic decompensation is really important in determining a possible cause. If the patient has alkalosis, consider a urea cycle. If the baby's acidotic, try to figure out where that acid is coming from by looking at lactic acid, aminos, and organic acids. Like, where is that acid coming from? Could it be an organic acidemia? Could it be a lactic acid? Something else. Certain smells can be a clue for metabolic disorder. And when I say that, if I'm writing an exam or anyone is writing an exam and somebody is telling you what urine smells like, underline it and take that really seriously because they're telling you what the answer is. I've read through a lot of these board exams, and you can, I know you're going to study a lot of what biochemistry showed you, but if you put that together with this, the questions will not be as overwhelming. They'll be like, oh, this is a 2-day-old that's really acidotic, and their urine smells sweet. And then they have elevation of leucine, isoleucine, and valine. And what could this be? And then you put maple syrup urine disease. So sometimes they'll even tell you which enzyme is deficient. So if you studied all the biochemistry stuff and you knew the branched chain amino acids are deficient, but often the questions have 2 or 3 clues to get you to the right answer. And then finally, adult onset glycogen storage disorders can present with muscle cramping and red-colored urine after exercise. So that concludes this lecture. If you're really overwhelmed, there is like a couple things in Thompson and Thompson, although they don't have a ton of stuff on inborn errors and metabolism. And I would try to put this together with the biochemistry stuff to not become overwhelmed. Thanks.